This is just an example of some mortality situations. If you look, and I checked, and this is just data that we get from the field. So we don't have an N there, which is quite concerning. How many people are we dealing with? We didn't know. But this is an example just to show you, number one, of the deaths that we were able to record. Most were cardiovascular. There were 9% of cancers. The point here is nearly all of the issues that we were dealing with, especially the deaths, were chronic diseases. And we do have the data, but I didn't show it here, of age, and the majority were of over 55, 60 years of age. Not a surprise. Just to show you some other examples that we're getting, this is not death, but referral. And this is from Kenya, and this is from Nairobi, though. But this is dealing with referral data from urban refugees living in Nairobi, mostly Somali, but also referrals from two major camp-like situations, the Dadaab camps and the Kakuma camps, Sudanese. Interestingly, though, more Somali than Sudanese now in those areas. So if you look at what we've been referring to, of course, medical pediatrics. So pediatrics, unlike older populations, are the big ones. Surgery, yes, but a lot of medical, meaning internal medicine, OBG, and most of the other that we did look at, and we have very specifics, but I had to put them together just for this chart, are infectious disease. Not a surprise, but again, it's limited data that you can deal with. But we need this data to be able to deal with, number one, what are the proper interventions we need to use, but number two, most importantly for referrals, money. How much money do we have? And we then get into the very uncomfortable position of rationing care, and that's what we've been doing more and more. We don't ration care for primary health care, but for secondary and tertiary care, and in particular in the Iraqi situation, we're rationing care, and we're dealing with a lot of ethical issues that we're really uncomfortable with, but we have no choice. And we have, because of the Iraqi crisis, we have actually now have referral guidelines, we have standard operating procedures for referral care, for referral committees. Very, very difficult stuff that is very sophisticated, I think, and UNHCR and many of the other organizations aren't prepared to deal with it. Two or three more slides. The next thing is, how am I doing for time? The next thing is integrating into the national health information systems. Extremely problematic. And so what we've been doing in camp-like situations, we have developed our own health information systems. As I said, even though we can say we need to integrate into existing systems, in camp situations we have our own parallel health systems, quite good information. And I'm pretty confident in that information. Here, I'm not. And some of the health information systems lack the flexibility in an emergency, whether it be for their own citizens or other citizens, to be able to, most health information systems have way too many diseases. Many of them you can't even diagnose in the areas where we are because the laboratories aren't functioning. So, and I remember this in Timor, you had to dramatically ask the government and work with WHO to dramatically simplify the existing health information system, and they either weren't prepared to do that or they couldn't do it in enough time, in a timely manner. The other issue is that many countries don't wish to disaggregate into nationals and others, whether it be IDPs and non-displaced, so their own citizens, refugees, others. Many of them don't want to add certain disease categories, and it's quite important. I mean, in many, obviously sexual violence, mental health are not existing in some of these areas, and we may need to add them. There may be other diseases that are occurring that refugees have, certainly injuries and specific injuries due to trauma that may not be in the existing systems. Here's just an example of Syria. So this was complicated, and it still remains complicated. We get a lot of data, but it's not always easy to deal with. So SART is the name. It's a quasi-governmental agency. It's basically government, and this is primary health care. So these are the number of patients treated in 2009. So if you look, we had 206,000 patients. And actually, I don't believe that's correct. I really think it's more 206,000 interventions. So another big idea, patients coming in, it's a clinic-based system, so they want to know x-rays. So I believe this is not patients, but actually interventions, but they reported it like this. This is all UNHCR funding, so it was a lot of money for us. 2.8 million, $14 per patient, per person. If you look though, these are the hospitals, and originally we had about 50 different hospitals. Now we have reduced it to this number, which makes it much easier to deal with in a practical manner. But if you look down, cardiac hospital, we're dealing with things, we're dealing, per patient or perhaps per intervention, $1,000. We're dealing with bypass surgery, stents, you name it. We're dealing with, in some areas, I'm going to get another one, is the oncology hospital. This actually seems quite low. But we have been dealing with paying for a lot of issues like thalassemia. We've been buying, in some areas, what we've been doing is the government will agree to give us, in order to get around some sanctions, the government will agree, the Syrian government will give us free care if we will agree to bring in an MRI machine. So we bought, not MRI, CT scan actually. We've been giving them a lot of equipment that helps the Syrian government. Yeah, and then we can, so we're trying to get access in that way as well, but it's a completely new situation for us. And I want to show you, okay, this is now, I'm trying to compare to Nairobi, just to give some examples. Completely different scenario, but if you look, that's $1,894. We have not a lot of people, but we have some people on dialysis. That's very, very expensive. When you have a limited amount of money, that's a lot. That is a lot. To put people on dialysis, the other big problem that we've learned from the Iraqi situation for referrals is to clearly distinguish expensive one-offs, i.e. cardiac surgery, to expensive chronic situations. So you're not going to start someone on dialysis and take them off the next month. You're not going to start someone for treatment of thalassemia. And that's been problematic. And let me show you the next slide, which is quite complicated. But I want to show you, this is where I would like to go eventually with our HIS. So if you look in particular, this was in 2009, just in Jordan, cost per treatment. This is only tertiary care or emergency care. So there are not a lot of patients here, and we have the exact number of patients. But we are spending $8,679 US per treatment. This is referral care. These are the number of patients, 16, 36, 17. You see it go way down, and then you see it jump up a bit. So from the second half of the year, we were spending 2,403, and here you had zero number of patients. This was purely due to money. So what happened is we had a huge amount of money at the beginning of the year. Suddenly the money went down, and then we suddenly got an increase of money at the end of the year, so the increase, which is not the way you want to do it. These are the number of treatments, and this is the amount of money. This line here is an approval rate. So if you look, we had to develop with Jordanian doctors, UNHCR doctors, and some NGOs. What we did is we have a referral committee. So because we couldn't spend all our money, so we didn't want to spend all our money on the complicated cases. So this was the acceptance rate, and you see it going down. Here we had no money, zero, and it's starting to go up. So we actually, and we have standard operating procedures for prognosis, vulnerability, etc., to deal with these complicated cases.